I'm Izzy, and I'm doing the session with Mark today on acute confusion. So this should encompass like a few of the modules. Actually, it should be quite interactive, quite fun. So let's make a start. So I guess like the main thing to start off with is like in your histories, like what is important to ask and get details of when someone comes in confused. Because to be honest, if you say to your consultant, this patient's confused, they'll be like, what do you actually mean? So it's important to ascertain whether it's like a memory problem. So is it that they're just not really understanding where they are? They're disorientated? Is it that their personality has changed and they're acting like out of the ordinary for them? Is it that it's more of a psychiatric problem where they've got these like new beliefs that they didn't normally have? So that could either be that they now believe that their friend is their enemy, or that they've newly become have new kind of religious ideology that is more extreme. But it's like a very difficult area, I think, to kind of work out what is just something new for them and what's abnormal. And you usually go off what the friends and family think, and also like what the psychiatrist says. And like I haven't done psychiatry yet, so I'm definitely not one to teach on this. And so I think we'll go from the more medical side and the more like organic causes of confusion. But it's definitely something to bear in mind that these organic causes can have a big effect on like someone's psychiatric well-being. And so it's also good to really work out as well what their baseline is. So are they normally coming from a place of like, Alzheimer's or like poor memory, and that therefore they've had a sudden deterioration? So that's really important to also list in your history. So I think what's good with confusion is it has a wide variety of causes, and so that we should be using our surgical sieve. So does anyone want to have a go at any of these? And it's not exhaustive, so I'm sure you'll come up with some ones that I don't have.
Encephalitis for infective.
Yep, so encephalitis, yeah. What would be another infective cause that's kind of on that same one? Oh yes, we've got high urea, which I totally didn't put on here, so points for Jordan. UTI, yep. So definitely UTI is something that does come up, and I think depending on who you talk to, it can be very overdiagnosed in the elderly. So it's something to definitely like be cautious about. But it is definitely something to think about. Legionnaires, Amadeus, I did not put that on, but like nice. Where do you get Legionnaires from? Zach, we'll ask you, put you on the spot. Digoxin toxicity, yeah, so like drugs is a big one, drugs. Pneumonia, yep, so like any form of sepsis, very nice. Yep, so Legionnaires from conferences with like bad aircon, nice, yeah. Such Spain. I guess like maybe like in an SBA they'd always put from Spain or somewhere. But I guess like anywhere really that just has like poor aircon and like stagnant water. Cool. So does anyone have any vascular ones? And not thinking like anything too major. Yeah, so stroke. Yeah. Yeah, so like there's vascular dementia, but I'm going to come on to that because like that is something that definitely you end up putting under acute confusion, but is it really that acute? Yeah, so good, Jordan. So that's one of the traumatic causes is like the lucid, yeah, the extradural hemorrhage. So yeah, so vascular for acute confusion, you've got stroke, so you'd look for a neurological deficit, you'd look for any change in sensation or motor function. Subarachnoid hemorrhage classically presents with a thunderclap headache, but they can come in confused afterwards, and you would have definitely you definitely have a very like quick eye on them to make sure that they're all right, and probably escalate very quickly. Infective meningitis, encephalitis, the standards really, maybe a funky abscess. Traumatic, you've got like, I mean, it sounds like stating the obvious, but like penetrating injury, epidurals or subdural hematomas. Autoimmune, like lupus, can present with confusion. Probably all the other ones can as well to a degree, but it's something to bear in mind that not all forms of encephalitis are due to an infective cause. So you do need to think slightly out of the box. And I think if you, especially at these tertiary centres, you'll definitely see it. And then metabolic wise, we've got hypoglycemia, which is like the great mimicker of everything. So anyone that comes through the door, these people can look like they've had a stroke. They can be confused and drowsy. So definitely like a blood glucose is on one of your list of things to do in your A to E. And then there's other electrolyte abnormalities that we'll touch on. And then, drugs is the big one. So like what new medications have been started? Are they consuming alcohol? Are they taking recreational drugs? And these in themselves can cause electrolyte disturbances. So it can be kind of a multifactorial confusion. And then neoplastic wise, so it's more common that you've got metastases to the brain than it is a primary tumors of the brain. But it is something to bear in mind, and they can do some kind of weird and wonderful things as well. But in general, like, is there a mass occupying lesion there or not? And so you'd be worried about raised intracranial pressure in these patients if they present with like headache, vomiting, and not being themselves. And so I think a big thing that like one of the Jerry's consultants said to me recently was like that if someone comes in acutely confused and is elderly or even slightly younger, like you can't say that that's Alzheimer's. You can't say that that's sort of like a congenital problem per se, because you would expect a more gradual decline in these individuals. And so even if someone comes in with Alzheimer's and has recently deteriorated a lot, you would be looking for an exacerbating factor. So like you'd be looking for an infection or trauma, have they fallen, that kind of stuff. So lupus, I don't know if Anush wants to answer this, but they get basically like autoimmune encephalitis. Yeah, it's magic. They get like antibodies to like certain receptors, maybe NMDA, but it's a bit sort of above my pay grade. But they can get these strange encephalitises, is how they present. So they can present quite like with psychosis, with personality change. So it is something that's quite difficult to pick up sometimes. But they'd probably also present with like the malar rash, the joint pain, that kind of stuff. Very interesting, like very interesting area, like for sure. And then neuropsychiatrics, so are they post-seizure? Do they have like a flare of their psychiatric illness? So that would be good to know. And then, like again, like drugs can have an effect. Cool, right. And then like time frames are really important. So, and that can indicate what the pathology is. So if the time frame is very, very sudden or like minutes, that this person has gone from being very, very normal to very not normal, what kind of things would you be thinking of? Broadly out of those groups. This kind of goes for anything, actually. Yeah, so if it's quick, it's going to be vascular. It's going to be like traumatic. It could even, or like a seizure. And then if it's kind of like hours to days, what could you be thinking of? And I fully didn't write absolutely everything on here, so I think it's definitely something to think about. But yeah, so like hours, days, infection, toxins, so that kind of stuff, drugs. And then longer, you're going to get things like, rumbling infections, dementia, cancers, that sort of stuff. I mean, some things can present very, very quickly. And Anush covered it with us last year, but like there was once a question that was, this person has got essentially dementia-like symptoms for a few months, and the answer was Creutzfeldt-Jakob disease, which is just like mad. But that is definitely not core knowledge. But they, for some reason, tested it, which was wild. And then, when you're presented with this person, are they hyperactive or hypoactive? Does it fluctuate? Are there triggers or precipitants? So a lot of the elderly that have a background of confusion or Alzheimer's can get very disorientated in the hospital setting. So actually they can get quite a marked improvement if they're sent home. So that is something to bear in mind, that like post anesthesia in an unknown environment, these people can be more confused than normal, not because of any actual organic pathology, but because of their change in environment. And also they can present with a bit of autonomic dysfunction as well. So like, are they now incontinent? That sort of stuff is really going to raise the question about if there's something quite significant going on. Cool. Okay, on to the cases. So we've got quite a few. So a 42-year-old female presents to A&E, and her husband is with her, and he reports that she's become muddled for the last 1 to 2 weeks and has been moody, aggressive, and has had poor concentration, and she's normally hard at work and is now like unable to concentrate. And so right now she's come in, she's complaining of abdominal discomfort, radiating loin to groin, which flares every couple of minutes. So the key bits of this history, which I've sort of like given away now because I accidentally pressed it and I forgot that I'd put these in, but so she's got this muddled kind of poor concentration off of her baseline, kind of psychiatric cognitive symptoms, and she's also got this abdominal pain. So I think what's good is you sometimes have to look at things individually before you completely piece them together. So which system would loin to groin colicky pain make you think of, and like what pathology? Yep, so renal, yep. And does anyone know like what specific pathology would give you that kind of on-off pain? Yeah, so renal stones. They may have urosepsis. You would want, in that case, you would want to do your observations. You'd want to check if they're feverish, that kind of stuff. But for the moment, we'll say that they have renal stones. So does anyone, oh wait, so hold on. So you've now got her in front of you. You're thinking she's got some renal stones. She's off her cognitive baseline. What sorts of bloods would you like to do for this lady? Yep, so Maddie's on it. Maddie knows the answer. So yeah, so you do some electrolytes, you do your Usenes, your FBC. Your ESR and CRP are good because you'd want to cover for that infection as well, because that would also put her off her baseline. You might also do, a little bit of like liver function, thyroid function. Yeah, so Jessica, like definitely the thyroid does seem to be the great mimicker at the moment. Like they've had patients at the Royal Free that have been on biochemistry incredibly hyperthyroid, but in person don't look too bad. So it's definitely something that could be missed on your initial bloods, but that could be present essentially. So you've done all those things, and overall, like you've sort of summarized her main problems. So she's got renal stones, she's got constipation, she's got psychological changes. So does anyone want to say what they think is wrong with this lady and what the likely blood test result would be that kind of clinches that? Yeah, so hypercalcemia. So yeah, like Maddie, Jessica, Jordan, well done. Like it's it's kind of one of those classic presentations. Sweet. And then on here you can see, so on this chest x-ray you can see the stone sort of chilling on like the left, just near the left kidney there. So some come up, some don't. It's a year 5 topic more than anything, but I think for 4th year it's good to know like the presentation. Defo. Cool. So the way that people end up remembering hypercalcemia is bones, stones, groans, and psychiatric overtones. So they get these like lytic lesions of the bones, they get calcium renal stones, and they get like this constipation, and they get depressed and confused, and this can have a bit of an insidious history. Does anyone know any causes of hypercalcemia? So obviously you've all recognized that they're going to have high calcium, but like there's a cause to high calcium. It doesn't just sort of happen on its own. So does anyone know any conditions that would cause it? Yeah, so hyperparathyroid, most common. And in that you would see a raised, like a high parathyroid hormone or a normal one. So a normal one doesn't exclude it, which was something I discovered recently. And then the other ones, yeah, you're thinking basically cancers, myeloma, sarcoids, like well done, guys. There's a few other things. So yeah, there's some drugs, so like thiazides can do it, lithium can do it. I just totally didn't put it on because I obviously forgot my own rule from previously about always think about drugs. Another thing that I've seen as well is like chronic immobility. So if this was a patient who was like paraplegic, they can also get a hypercalcemia as well. And so malignancies wise, can anyone think of any specific malignancies that can do it and why? So yeah, sorry, apart from myeloma. So yeah, definitely myeloma. Can anyone think of like a solid organ tumor that can do it? So not small cell lung cancer. So yeah, breast can do it because it can metastasize the bone. So anyone that metastasizes the bone can definitely do it. There's just one that's kind of like a classic and also a bit of an SBA one. So you're on the right lines with small cell lung cancer, but just think of a different one. Which non-small cell lung cancer? I'm going to push you now. Which one? Is it going to be adeno or is it going to be squamous? Oh, I'm really sorry. It's squamous. No, I do that all the time. So the squamous cell produces parathyroid-like peptide, so that can push it up as well. Small cell can produce like ACTH and stuff and produce this kind of like serotonin syndrome. I've also seen the high calcium due to renal cell carcinoma. So it's not, I would say like anything's possible, but one of the classic things that a squamous cell carcinoma of the lung can do is produce PTH. Funky. Okay, on to the next one. So, an 83-year-old woman comes to A&E. She's brought in by her carers as she's drowsier than usual and confused, and they're concerned that she may have a UTI due to foul-smelling urine. On examination, she's sleepy. She has a GCS of 13 out of 15. She cannot give you a good history, and the carers say that they must leave to look after their other clients. On examination, she has a leg that is externally rotated and shortened with marked bruising and extreme pain when lifted. She has an abrasion to her left scalp. She is constipated and has lower abdominal tenderness. Her past medical history includes mild dementia, atrial fibrillation, type 2 diabetes, sensory neural deafness, and knee osteoarthritis. She's on bisoprolol, warfarin with a target of 2 to 3 INR, and naproxen. You do a urine dip and it's suggestive of a UTI. Your colleague wants to prescribe gentamicin and discharge her home. What has your colleague missed? So I think like, obviously it's a big history. So I think just like pick things out that you think like I'd probably want to investigate that further or maybe do something differently. So yeah, Zach, like fractured neck of femur you'd be worried about because of the way that the classic for SBA especially is like externally rotated and shortened leg, agonizing to movement. So, and that would kind of suggest she's had a fall. And I know this might seem unbelievable that the carers wouldn't have mentioned it, but like you've really got to look at the patient yourself and decide because the story that you can get can be quite different. I mean, I've seen a patient who's got raging cellulitis and they said that they only noticed it yesterday and they were normal yesterday. And so obviously, it really depends. And then, head injury and they're on warfarin and they've probably got a fractured bone. So they're going to be bleeding out their bone on warfarin and not coagulating. So it's not really good, is it? And then Marc has gone in with the big flashing warning of like, so she's got sensory neural deafness. Maybe I should have put in one ear, but you would never ever give gentamicin to someone with ear trouble because it's both ototoxic and nephrotoxic. So you'd be very worried about giving it to her in this. It's probably also not the best thing to give her for simple UTI. You'd probably go for like nitrofurantoin or trimethoprim. She could be in urinary retention as well because the elderly commonly can be, and that tenderness could be a really, really full bladder. So yeah, you're right, Zach, you do like a bladder scan as well. And so overall, like your colleague's not really done a particularly thorough job, but like we ain't gonna judge because they are made up. But so you've kind of all picked up on these things. So I guess firstly, the X-ray gurus come round and they do one for you. And so can anyone tell me like what the abnormality is? Yeah, so right, very nice. Intracapsular neck of femur fracture. So yeah, that is correct. Yeah, nice. So yeah. So I like to just sort of draw round stuff if it's less obvious. I think in the exam you would get an obvious one, but also some of the photos are a bit blurry sometimes. So I think, yeah. And then as like Zach said, you're very worried about these fractures, the intracapsular ones, because you risk avascular necrosis of the femoral head. So, and they're also got an incredibly high mortality. So it's good to kind of sort of draw these imaginary lines, Shenton's lines as well. Look for any kind of pelvic brim fracture as well that can go missed. And so yeah, that's where the fracture is. And then, you know, you may argue this is a very comorbid patient, but actually like the mortality is so high from neck of femur fractures that really she should have this fixed. And but that doesn't mean to say that she shouldn't be optimized before the surgery. And obviously, like, we've got the other factors to consider. So so regarding fractures, we'll finish on we'll just sum up fractures for a bit. So so we've said for intracapsular fractures, there's a risk of avascular necrosis of the head. What are the treatment options that we could consider for this woman? Yep. So hemiarthroplasty, very nice. So yeah, especially if displaced, yeah. Depending on mobility. Or total hip replacement if less mobile. So probably for her, we'd go with like total because she's from a nursing home and it sounds like she has a very like poor baseline and therefore she doesn't need kind of as much of the diverse range of movement as a hemiarthroplasty would do, which is more preferable for the younger patient. So for young patients, if they're under 60, they may even just do internal fixation, which is like 2 rods in, because the likelihood of them doing of getting avascular necrosis is lower. They've got a more resilient bone health, basically. So they might just do that. And then hemiarthroplasty will be for your independent over 60s, and then total knee for LD with reduced mobility. What would you do if it was like extracapsular? So if it was intertrochanteric or subtrochanteric. So if you look like, if it's either the orange part of the bone or the red part of the bone, what would you do? So yep, so DHS if intertrochanteric and yep, intramedullary nail if subtrochanteric. And I literally found like the best photo ever when I was like yesterday, which shows all of them. Hold on, just wait for it to like load up. Yeah, nice. So I think this is quite a good one to look at because you could get this in an OSCE of like what they each look like and what the patients had. So the parallel implants look quite unique, but when you're looking at the sliding hip screw versus the IM nail, just note that the IM nail goes a bit further down the shaft, and also it's kind of in, I guess, like the sliding hip screw is in more of an L shape, whereas the IM nail is in more of a Y shape, is how I like to think of it. And then the hemi and the total has a prosthesis for the actual kind of cup of the pelvis, like the acetabulum, whereas the hemiarthroplasty is just the femoral head, unless it's reversed over in the intertrochanteric region, and then it's the nail, I think. Yeah, so there's probably definitely some nuances that I've totally forgotten from last year. I think it's all to do with the decision that they make is definitely based on like the patient's functional status, what the patient wants. Also, if it's displaced, undisplaced, comminuted, so in multiple pieces or not. So for the, yeah, it kind of gets a bit fuzzy around the intertrochanteric area really, but yeah, I think you're probably right with like the oblique, but I can't think right now, sorry. It's probably like some, yeah, we can have a Google. Cool. So this is 2 separate patients, but 2 options for your woman's head abrasion. So does anyone want to have a go at these? Like, what's the left one and what's the right one? Yeah, so extradural on the right, subdural on the left. Yeah, nice. So I guess the key with these is like it's to do with the shape. So subdural is classically like the sort of that crescenteric shape, whereas extradural is much more kind of, I guess, like much more obvious, really. How would the histories differ between these? Like the kind of, how would the patients present differently if they had a subdural versus a extradural? And obviously on both of these, you can see a midline shift, so they're going to definitely come in much more unwell. Yeah, so actually you're right. So there's a bit of a lucid interval between an extradural. So I guess a classic would be like someone has a very like high impact head injury while skiing, passes out, wakes up, feels totally fine, and then just suddenly collapses, and like you can basically just die because whereas a subdural, they can kind of, yeah, like Jordan, they can basically kind of go a few weeks, get a bit worse. And that usually happens because you have this like bleed, which doesn't really produce that huge mass effect of an epidural, but it draws water in slowly and increases in size as the bleed gets older. And yeah, a subdural is much more likely in the elderly falling at home. Does anyone know like why they get it? I think I've touched on it in a previous session as to like why the elderly are more prone to subdurals. It's the same for those with like Alzheimer's as well, and those who drink alcohol quite a lot. Yeah, so the bridging veins are weaker. So it's essentially that like as you grow older, your brain basically shrinks. And so if you have chronic alcohol use, you also get that destruction of the brain. I mean, you are also have poor coagulation as well, but in general, like you get this brain shrinkage, and you do with Alzheimer's, and the space between the bridging veins go is much wider. And so, yeah, they are much more prone to breaking. So that's why an elderly person may have the same fall as you or I and develop a subdural with a very minor injury, whereas we would be okay. And so, yeah, I've included this diagram because I think it's quite useful just to illustrate like the differences between them and like what you can look for on a CT. Cool. And then we sort of discussed that they were on like anticoagulation. So I've put this in for like everyone's use. So but this is definitely something that like you need to know as a doctor, and also will come up in exams, is that the management of someone on warfarin, if they are actively bleeding or not actively bleeding, and you find that the INR is very high. So if they're actively bleeding, you're going to want to definitely stop the warfarin. You're going to want to measure your INR, and you know, likely in this case it's going to be a bit raised. And so you can give vitamin K, but that will take hours to work. So if someone has got bleeding varices or a huge GI bleed, or a fracture that's bleeding, you're going to want to give like a prothrombin concentrate through IV, monitor them very carefully, and try and get that balance right of getting some coagulation but not sort of overdoing it. If they've got a minor bleed, you might take it a bit more slowly. So you might stop the warfarin, give the vitamin K, see how they go. Obviously looking at like their observations to see if they're hemodynamically unstable. And then if they're not actively bleeding, or their INR is between 5 and 8, so not too scary, you might sort of hold the warfarin, give a bit of vitamin K, or just hold it. And in general, like you're waiting for it to get back into that normal range or close to it before you restart. And then you might decide to choose a different dose. And so what are some kind of key drugs that can really mess with your warfarin? So either like potentiate it or reduce its efficacy. That is like kind of bread and butter stuff. Yeah, so phenytoin, so like what would phenytoin do? Yep, so rifampicin, so that's an inducer. And then the same with like grapefruit juice, so those are going to reduce, so warfarin is going to be metabolized more quickly, so you're not really going to get like the anticoagulant effect that you want. Same with St. John's wort. St. John's wort is like a classic one that like young people may take, and therefore like it can reduce the efficacy of like the contraceptive pill. It's kind of like the most nightmarish herbal remedy really for drug interactions, and usually you're trying to advise patients that actually it's probably like just causing more harm than good by messing up with their dosages of their medications. So yeah, you want to really know, like ham home your like P450 inhibitors, your P450 inducers, and really like pick up on those like relationships. So I mean, a big one is like macrolides and statins together is like another big interaction because of this. So it's definitely like something to think about and is quite examinable. Okie dokie. Cool. So I think we're on to like Marc's bit. If Marc wants to take control of the slides, and then we'll be back to me. And basically, if we like overrun or whatever, we'll save the next ones for the next session. So don't worry, we'll like cover them all at some point.
Cool. I'll take it. Okay, so case. I'm going to cover an important cause of acute confusion. We'll start off with a case. So you've got a 22-year-old college student coming to you, brought by his roommates. They notice he's been acting very strange over the past day, misplacing objects in the kitchen, mumbling incoherent to himself whenever they try and talk to him. He's been isolating himself in his room. They got very worried when they found him very drowsy and sweaty on the floor in his room. You were unable to get a coherent history from the patient. He keeps mumbling. His head hurts. What's the first step in your assessment? Very good, Dr. A, B, C, D, E, and yes, this is actually based on a noosh on a normal day. So, A, patent, no noises. His saturation's 95 on room air. There's nothing on his chest. Capillary refills about 4 seconds. BP's 95 over 76. He tried to elicit his JVP. He failed to do so. His weak, thready pulse, and he's no other sounds in his chest. His glucose is 6. His GCS is 12. M5, V4, E3. Just be sure to go over the GCS score because it is something that they might ask you to calculate. And it's something that with a bit of practice, it's easy to do. AMTS is 6, temperature is 38.1. His pupils are 5 millimeters, equal and reactive, but they are sluggish. He's flushed and sweaty, and there's a rash on both his legs. And this is the rash that you find. Can some brave soul please tell me what to see? Good. Okay, there's a good differential. They're a bit big to be petechial, Jordan. So Patrick, you've got the right part of the differential, but what I want you to do is, yeah, purpuric. So do you guys know the difference between Petechiae, Purpura, and Echimosis? Okay, the Petechiae are very small. The main difference between the three is the size. The Petechiae are very small. They're usually between 0 and 5 millimeters. Purpura are bigger, so they're usually up to 1 centimeter and above. And then Echimosis is a bruise, so anything above 2 centimeters is a bruise, okay? But yes, it's a non-blanching rash. It's a purpuric rash, okay? Fine, so you find he has a purpuric rash on his legs. This is another example. So what do we see on this? This is a very good example that Izzy found of a child's leg with another purpuric rash. Just so you know that there's different. It may look very different in different presentations. What do we see in the palpable conjunctiva of this kid's eye? Yeah, petechiae. You see small little hemorrhages. You see small petechiae in the conjunctiva. Well done. So, what else would you like to assess? So you've done an AGE assessment. You think he's fairly sick. Given the other presentation, what other examinations would you like? Are they photophobic? Full examination, so full neuro examination. Yeah, I would agree. Fine. So your neurological examination is very difficult because he's confused and he's not very compliant. However, to tell the difference between an upper and lower motor neuron lesion, the main parts of the neuro examination that will give you this information is tone and reflexes. And thankfully, you don't need a patient to understand instructions to when you're doing tone and reflexes. If the patient's very confused or comatose, then it's something you can elicit. So it will give you the most information. So his tone is normal, and his reflexes are slightly reduced. He's unable to bring his chin to his chest, partially because he doesn't understand the instruction, but also because he's got very stiff neck. There is resistance to passive extension of his knee when his hip is flexed at 90 degrees. And it's very painful to do so. What are your differentials? So one has been mentioned so far. What other differentials do we have? So remember, in fourth year and fifth year and final year, you're meant to go broad with your differentials and then narrow down. I've given you quite a bit. Yeah, subarachnoid hemorrhage could be one. Acute confusion, neck stiffness, headache. Encephalitis, yeah, very good. Acute onset confusion, headache, fever. I'll give you that this patient is also photophobic, so that fits in as well. TB encephalopathy, yes, but it would be a bit longer onset, so the timeline would be a bit more subacute. Plus, he would have a history of TB. But I like your thinking. Carbon monoxide poisoning, another good differential for acute onset confusion. The only thing is, in the history, his housemates might also be confused as well. They might also be brought in. He'd also be flush red and red lips. So good, some good differentials. So we think that this is either meningitis or encephalitis. What I want to highlight to you guys is there's a very large overlap between the two, and it's sometimes difficult to differentiate between the two. So meningitis is inflammation of the meninges, which is the layers surrounding the brain, whereas encephalitis is inflammation of the parenchymal substance of the brain. How can you classify meningitis? Does anyone know? So what are the different etiologies of meningitis? Let's see. Viral, bacterial, yeah, by the type of organism. Very good. So viral, bacterial, you can have infective autoimmune. So you can have viral, bacterial, autoimmune. Good. Aseptic is just another way of saying viral meningitis. Good. You guys left out fungal though. You can have bacterial, which is septic meningitis, viral, which is aseptic meningitis, fungal, spirochetal, and TB, which are chronic meningitis. You can also have autoimmune, which I left out on this list because I wanted to concentrate mostly on the infective causes. Versus encephalitis, what are your primary causes of encephalitis? Yeah, it's pretty much just viral, really, or spreading from the meninges. Symptoms are very similar. So headache, acute onset confusion, reduced GCS. Neck stiffness is much more common in meningitis than it is in encephalitis, but you can get neck stiffness in encephalitis as well. Signs: nuchal rigidity, Koenig's and Brudzinski's. So so on the examination slide, I mentioned that he was positive for one and it was difficult to assess the other. but he's technically positive for 2. So Kernig sign, does anyone know what Kernig sign is? Other way around. Brzezinski's is the neck one. Kernig's is when you attempt. So Kernig's is when you flex their hip joint at 90 degrees and their knee joint at 90 degrees. When you try and extend the knee from that position, it's either there you get resistance or there's passive flexion of the hip when you try to extend. Good. So Kernig's is the hip. Brzezinski's is the neck. I would still do an IRL if you suspect. Yeah, yeah, I would still, because they're quite classic signs. Good. And in comparison, so encephalitis, there might be focal neurology. They're more likely to develop seizures. There's hemiparesis, may get aphasia as well. I'm not sure about the sensitivity or specificity, but it would be part of a complete exam, I would say. I would just do it as part of a complete exam. So, causative organisms. Anyone know some? Oh, I've given it away. Bacterial meningitis. Your main causes are Neisseria, strep pneumonia, H. influenzae, Listeria, usually in the very old or in the very young, and Group B strep. Not as important for you guys this year, but very important next year when you do pediatrics. Then you have your viral causes, which are all the same as encephalitis, and then your fungal causes, Candida albicans, Aspergillus, Cryptococcus neoformans. Anyone know some of the common viruses that cause encephalitis / meningitis? HSV, very good. That's probably your commonest one. Yes, that's correct. Enteroviruses, JC virus, very good, Patrick. JC virus in the context of what other infection? The JC virus doesn't normally cause an encephalitis yeah, very good, HIV. The JC virus causes progressive multifocal leukoencephalopathy, which is seen in the context of HIV. Also in the context of MS. I actually didn't know that. Good. You've pretty much hit. And CMV. Very good. CMV also in the context of HIV. So yeah, HSV, enteroviruses, mumps, HIVs, which in the context of also CMV and JC virus, arboviruses, and rabies virus. Good. So, given the presentation, and we think that it's meningitis or encephalitis, which is what I wanted to kind of highlight, is that it could be either or. It's very difficult to differentiate the two. What would your investigations be? Laura, I think you might be thinking of Creutzfeldt-Jakob. No, did I? I think you might be thinking of Creutzfeldt-Jakob, which is prion disease. Okay, right. Why is everyone jumping to LP first? Every time I do this, you guys know by now, I want bedside first, blood second, imaging, then special test. Very good, Zach. You do want to confirm there's no raised intracranial pressure before you do an LP by fundoscopy and CT. Most people aren't that good at using a fundoscope nowadays, so usually first line is to do. Good. What do you want to do by the bedside? I've told you this guy's very, very sick first. Why does this? Okay, there we go. Okay, good. Yes, obs. Very good. Very good. So you want to do your observations first. He's very sick, continual observations, and you want to monitor his urine output. This guy is septic, right? His blood pressure is tanked. He's clammy, he's sweaty, his peripheral capillary refill time is like 4 or 5 seconds, okay? Good. Now, we're talking about bloods. So you guys correctly identified FBC, CRP, lactate, VBG. What else do you want to do? Clotting, very good, because he's got what looks like meningococcal sepsis. So you guys have already mentioned an LP. If you're considering doing very good blood cultures, if you're considering doing an LP, so you're correct in saying blood cultures, but if you're considering doing an LP, what do you need from serum to compare to CSF? Does anyone know? Blood glucose, fantastic, good. Yes, so you're going to do blood glucose as well. So you've correctly identified. I would do an ABG because this guy is septic. I would do an ABG rather than a VBG because you can also get tell his tissue oxygenation is. Oh, sorry, his arterial O2 as well, just in case. Albumin, I'm not too sure. You could run LFTs as well, but I don't think it's on that high on the list. But the main one is FBC, use and ease LFT, CRP correctly identified, glucose cultures, coagulation screen, and a blood gas. Imaging. So as correctly identified by Zach, you are worried about raised intracranial pressure. So what imaging do you want to do on this patient before you do your LP? MRI is a bit slow. In the time that you take to do an MRI head, you've kind of wasted a lot of time. So CT, very good, CT head, right? And then you're going to do your LP, right? Which includes your cell count, differential, glucose protein, and then your specialty stuff, which is your serology or your cultures, okay? Good. Now, because you are good medical students, correctly identifying all the investigations, I've got this for you. Who wants to tell me what they see in this eye? You take a fundoscope, you go, oh, before he goes into CT scan, I'm going to have a look at his eye out of curiosity. What do we see on this image of the retina? Papilloedema, very good. Yes, so you've lost that is papilloedema. So you've lost the the optic disc and physiological cup, okay? So there's swelling of the physiological cup. Correct. And does anyone know any contraindications for an LP? One of them, which is already mentioned, or one of them, which is a sign of one of them. Raised ICP, very good. Yeah, clotting deficit, yeah, because they may bleed. That's a nice picture of an optic disc, right? Subarachnoid hemorrhage. You will do Patrick. You'll do space occupying lesion. Yes, subarachnoid hemorrhage. Actually, an LP is used in the diagnostic of a subarachnoid hemorrhage, which I'll come to show you now because I'll go through the different analyzing an LP now in a second. So yes, raised ICP. Neurological history. So if they have hydrocephalus, if they have a shunt put in, have they had post-op? Are they post-op? Yeah, Chiari malformation because you're worried they're gonna herniate the tonsils even more. Good. And as mentioned, coagulation disorders, including, well, you can include meningococcal sepsis, but you got to weigh it up based on the diagnosis. That takes clinical judgment. I mean, most of the time you won't be doing an LP yourself. You will be it's a registrar or a consultant will be doing the LP. And this is how you interpret it. So the main things you're looking for when you're asked to interpret CSF is the appearance of it, the opening pressure during the LP, the cells and the differentials.
She's very nervous about her
Protein.
She says she's got high iron levels.
Glucose, and then you have your special tests. So the main thing is bacterial is a turbid appearance, a very cloudy appearance, whereas the others tend to be clear, except for subarachnoid, which has a xanthochromic or a blood stain. So xanthochromic means it's just very orangey yellow or blood stained appearance. Opening pressure, bacterial has a very high opening pressure, whereas the others are just elevated, but not as highly elevated. Cells, main thing is bacterial, very high number of cells, predominantly neutrophils, whereas, again, everything else is moderately raised, but predominantly lymphocytes, and subarachnoid has none. And protein, again, markedly raised in bacterial, moderately raised in the others. Glucose is always compared to serum. So in bacterial, you have a great reduction. It's less than 40% compared to serum glucose, whereas viral, it's normal, and same with the TB and fungal. They're reduced, but not as heavily. Yeah, you'll find your own way to remember it, but the main point is yeah, actually, can finish some mnemonics. The main thing is just practice going through this. It's appearance, cells, opening pressure, protein, glucose. That's the main things you need to remember when you're interpreting it. Treatment. So we suspect that this is meningococcal sepsis. How are we going to treat this guy? And remember, I told you he's very sick as well. We think he's septic, and he has meningococcal disease. Very good. Sepsis 6. You probably all know the sepsis 6 at this point, so I'm not going to bother going through that. But yes, treat his sepsis. Right. Anything else? Cefotaxime. Yeah. Antibiotics. You do the antibiotics after the LP. However, don't let the LP delay starting treatment. Yeah, so in terms of, I've got it here. So it's plus or minus amoxicillin. Do you know what the amoxicillin treats, Zach? Yes, yeah, listeria. So as I mentioned, either the very old, pregnant, or the very, very young are at risk of listeria. So that's when you will give them the amoxicillin as well. So it's usually ceftriaxone for 2 grams BDIV. And if they're pregnant, greater than 55, or immunocompromised, or very, very young, you don't have to worry about that now because pediatrics is a fifth-year topic. But if they're very, very young as well, it's ceftriaxone plus amoxicillin to treat for listeria. Okay. And then encephalitis, since it's predominantly viral, think about adding acyclovir. So again, this is the point. If you're dead certain that this is a bacterial meningitis, then treat with antibiotics. But there's a blurring of the lines between whether something can be just meningitis or encephalitis, and that's why people sometimes use the bridging term meningoencephalitis. So that's where you need to debate whether are you going to treat this purely as bacterial or purely as viral. Sometimes people start them on both treatments and then wean one of the treatments when it's made clear after the CSF comes back. Good. Complications, I've already named one. So cranial nerve palsies. Anyone else know any complications of meningoencephalitis or meningococcal sepsis? Loss of hearing, yeah. So that would be another cranial nerve palsy, but yes, yeah, deafness, sensorineural deafness. Anything else? DIC, very good. A complication of meningococcal sepsis. Another complication of meningococcal sepsis. An eponymous term. Does anyone know? Very rare cause of acute Addison's. And Coney anemia. I'm not entirely sure about that, Zach. I'll have to look that up. Yeah, Friedrichsen-Waterhouse syndrome. So that's bleeding into the adrenals, or hemorrhagic destruction of the adrenals. Good. And any other complications of just meningoencephalitis in general? Right. Okay. So you guys correctly identified some of them, but yeah, cranial nerve palsy, deafness, subdural empyemas, parenchymal abscesses, obstructive hydrocephalus, DIC, seizures, SIADH. Same with any intracranial injury can cause SIADH. Learning disabilities and cerebral palsy, especially if they're very young. Good. So that's all I have to say about meningoencephalitis. If there's still time and you guys want to hang around, Izzy's got another case for you.
Yeah, so it's completely up to you guys. If you'd rather that we put it onto the next session, then like we can do. There's like a bit left. A bit of like bit of liver, bit of neuro, but it's like 7 p.m. and you might want dinner, so up to you guys.
We'll be doing a confusion part 2 later on, probably not next week, but we'll do it one of the other weeks as well, so we can save it for then if you guys want.
If you're kind of on a roll. Yeah, next session. Yeah. Sounds good. Put in the feedback if you want. We'll put the link. Maybe Anoush will do it because Anoush is capable and I am incapable. Just put like anything else you guys want in future sessions. Like we completely sort of just make these for you guys. So yeah, we'll put it into the next acute confusion with some other things, some of the other things that we haven't covered just yet. So, and we'll keep it a bit. I mean, your feedback's great. Like definitely.